Hello everyone and welcome to our module on tubulointerstitial disorders. Let's start by talking about acute tubular necrosis. Acute tubular necrosis occurs anytime there's sudden damage to tubular epithelial cells. These cells will slough off and fall into the nephron of the lumen, causing renal disease. There are a number of potential causes. One of the main ones that you'll see clinically is ischemia. Any cause of a severe decrease in blood flow to the kidneys can cause acute tubular necrosis. And then there are other causes like drugs and toxins. And the main clinical problem caused by tubular necrosis is acute kidney injury, which I talk about in another video, but the BUN and the creatinine will rise because the kidneys are not filtering blood normally. In acute tubular necrosis, tubular epithelial cells die and slough off into the urine, and when this happens, they obstruct the flow of urine through the nephron. And this will lead to clinical features of intrinsic renal failure. In acute renal failure, the GFR falls and the BUN and creatinine rise, and there are different patterns of acute renal failure. I talk about these in another video, but the intrinsic pattern of acute renal failure is what you see in tubular necrosis. In addition, those epithelial cells that slough off will form casts in the tubules of the nephron, and you can see these under the microscope if you examine the urine of patients with ATN. Shown on the screen is a picture of a typical cast that's seen in ATN. It's described as a granular cast or a muddy brown cast. There are a couple of phases to acute tubular necrosis. Once the condition begins, the patient initially enters what's known as the oliguric phase, and it gets this name because the patient will have oliguria, meaning decreased urine output. The BUN and creatinine will rise, and the patient can develop hyperkalemia, as well as a metabolic acidosis. And this phase can last up to a few weeks in some patients. Once patients turn the corner and begin to recover, they enter what's known as the polyuric phase. This phase gets its name because patients are polyuric and produce lots of urine. This is a good thing because it means the patient is recovering, but in this phase there's so much urine output that you can potentially lose potassium in the urine and develop hypokalemia. So whereas hyperkalemia is seen in the initial oliguric phase, hypokalemia can occur in the later polyuric phase during recovery. The diagnosis of ATN can be made by finding clinical features of intrinsic acute kidney injury. And again, I talk about intrinsic acute kidney injury in more detail in the video on acute renal failure, but by way of review, in intrinsic acute renal failure, the BUN and creatinine will rise, but the ratio of BUN and creatinine will be no more than 20:1, and the fractional excretion of sodium will be greater than 2%. The diagnosis is also indicated by urinalysis showing muddy brown casts. And then finally, one of the ways you know clinically for sure that a patient has ATN is when their kidney function does not improve with IV fluids. That's what happens when tubular cells have died and are sloughing off. As I mentioned at the beginning of this video, toxins are one of the potential causes of acute tubular necrosis. And one substance that's potentially toxic to the kidneys is the intravenous contrast dye that's injected in order to obtain a CT scan like this one shown on the screen here. And when contrast dye causes ATN, it's called, obviously, contrast-induced ATN. And contrast-induced ATN has some special features, so let's talk about that now. First of all, the onset of contrast-induced ATN can be very rapid. It can cause acute tubular necrosis within 24 hours of exposure. And usually the acute tubular necrosis is non-oliguric, meaning that the BUN and creatinine go up, there may be casts in the urine, but the patient does not develop oliguria. Important risk factors are chronic kidney disease and diabetes, and this is clinically relevant because patients with advanced chronic kidney disease are often not referred for contrast CT scans, and the reason is because the risk of contrast-induced ATN is so high, and it can potentially push them into the need for dialysis. There are thought to be two mechanisms of contrast-induced ATN. The first one is direct toxicity of the contrast dye, and the second one is spasm of the afferent arteriole leading to ischemia. And one thing to know for your board exams, because this may come up, is that contrast-induced ATN has unusual urinary findings. As I said before, most patients with ATN have findings similar to intrinsic renal failure with a high fractional excretion of sodium. However, in patients with contrast-induced ATI, for reasons that aren't entirely clear, the urinary findings are usually similar to pre-renal acute kidney injury, with a very low fractional excretion of sodium, and it's thought that possibly this has to do with the fact that the afferent arteriole spasms and causes reduced blood flow to the kidneys. You can reduce the likelihood that a patient will develop contrast-induced ATN if you hydrate them with normal saline before the study. So for this reason, especially in patients who don't have completely normal kidney function, intravenous hydration is given prior to sending the patient to the CAT scanner. I mentioned earlier that some drugs can cause acute tubular necrosis. Let's talk about that now. First of all, a number of antibiotics are associated with ATN. Some of the important ones are vancomycin, aminoglycoside antibiotics, and amphotericin, which is used to treat fungal infections. And then there are other non-antibiotic drugs associated with ATN. Some of these I've listed here. Cisplatin is used as a chemotherapy agent for cancer. Acyclovir is an antiviral drug, and cyclosporin is an immunosuppressant. And one thing to know about ATN from drugs is it doesn't happen after the first dose. It usually takes about 5 to 10 days of being on an antibiotic or another drug associated with ATN for renal failure to develop. So in a board question, if they tell you the patient just started the antibiotic yesterday, it's very unlikely that that drug is the cause of ATN. And then finally, acute tubular necrosis is a dose-dependent adverse effect. So clinically, we try to use the lowest dose possible of a drug for the shortest period of time to prevent renal complications. The treatment of ATN is supportive. Basically, you monitor the BUN and creatinine and the urine output. Some patients will require temporary dialysis, but kidney function usually recovers. That's the standard course, is that this is like a shock to the kidneys, but they usually recover. And the reason they recover is because the tubular cells of the nephron are capable of regeneration. They can undergo a process called tubular reepithelialization and come back to normal after having had ATN. And for your board exams, always remember that treatment is just supportive. There's really nothing to do beyond monitoring the patient. Treatments like diuretics, steroids, or low-dose dopamine to improve the renal blood flow, none of these things have been shown to be helpful. I told you before that when patients enter the later phase of ATN, the polyuric phase, that they can have low potassium. You should know, however, that they can also have hypomagnesemia because they will waste magnesium by having it go out in the urine during the polyuric phase of ATN. And it's very important and very high yield for you to remember that the potassium cannot be corrected if the mag is low. Low magnesium promotes potassium loss, and so if you try to treat the hypokalemia with potassium supplementation but you don't address the hypomagnesemia, the potassium will not correct. Our next disorder is acute interstitial nephritis, sometimes called AIN. It's also sometimes called tubulointerstitial nephritis. And in this condition, there's inflammation of the renal tubules and the interstitium, which is the space between cells of the glomeruli and the nephron. This is a hypersensitivity or allergic reaction. It's mediated by eosinophils, like this one shown on the slide here, and neutrophils. And it's usually triggered by drugs, although as we will discuss, sometimes an infection or an autoimmune disease triggers AIN. And it usually resolves when you stop the offending drug that's causing the condition or treat the infection. The main clinical feature of AIN is acute kidney injury. So someone will be exposed to a typical triggering drug, and a few days later they will develop acute kidney injury. There will be no evidence of nephritic or nephrotic syndrome, and this is important because if a patient develops acute kidney injury and they have things like red blood cell CAS and dysmorphic red cells, this suggests glomerular disease, and that patient probably has glomerulonephritis, not AIN. The majority of cases of AIN, about 75%, are caused by drugs. There are many, many drugs that have been reported to cause this, but I've listed some of the common ones on this slide. Sulfonamides are a classic cause, so is rifampin, which is a tuberculosis drug. Beta-lactam antibiotics like penicillins and cephalosporins can cause acute interstitial nephritis. It's been reported in patients taking diuretics like furosemide, bumetanide, and thiazide diuretics, and then it's also been reported in patients who are taking NSAIDs. A small number of cases are associated with infection or a systemic disease. For the infectious cases, multiple organisms have been described. Some of them I've listed here. They probably won't ask you which organism caused this on your boards because there are so many that have been reported. But some of the ones that have been reported include Legionella, Leptospira, CMV, and tuberculosis. And in terms of systemic diseases, these are all autoimmune diseases like sarcoid, Sjogren's syndrome, or SLE. Patients with these conditions have been described as developing AIN. So the classic presentation of a patient with AIN is a patient who's exposed to one of the triggers we just discussed. That patient then develops features of an allergic reaction like fever, maybe a rash, maybe malaise, and then lab testing shows acute kidney injury with a rise in BUN and creatinine. In addition, when you examine the urine sediment under the microscope, a classic finding is white blood cell casts. This is a picture of a white blood cell cast shown on the screen here. Normally, white blood cell casts are associated with pyelonephritis, but you should be aware that they can also occur in acute interstitial nephritis. Now, you may wonder if patients with acute interstitial nephritis have fever and white blood cell casts, how do I tell that they don't have pyelonephritis? Well, the way you can tell is because they'll have no symptoms of cystitis, so they will have no burning on urination, no frequency, no dysuria. And when you examine the urine, you will not find any bacteria. This is called sterile pyuria, meaning you have white cells and white cell casts in the urine, but no bacteria. Make sure you don't confuse this disorder with pyelonephritis that commonly happens on board exams. In addition, because this is an allergic reaction, you can see peripheral eosinophilia, and then sometimes you can see eosinophils in the urine, although this is a rare finding and it's not reliable. As I said before, the treatment is to stop the offending agent if it's a drug. Rarely steroids are required, and rarely acute interstitial nephritis progresses to become papillary necrosis, which we're going to talk about next. Somewhat related to acute interstitial nephritis is another condition called chronic interstitial nephritis. The main difference here between chronic and acute interstitial nephritis is that in chronic nephritis there's a mononuclear cell infiltrate rather than eosinophils and neutrophils. In addition, because this is a chronic inflammatory condition, fibrosis and atrophy of the tubules can occur. This is almost only seen in patients who have long-standing use of NSAIDs, sometimes also called analgesic nephropathy. So in a board question, this will be a patient who's taking lots of NSAIDs every day for a condition like back pain or arthritis. That patient will have a mild chronic elevation of BUN and creatinine, and it will get better if you stop the drug. And I've summarized all these elements of a classic case here at the bottom of the slide. Let me pause and briefly talk about NSAIDs and the kidneys. NSAIDs are associated with a lot of different kidney problems, and it's hard to keep them all straight. So I've listed them all on this slide, and let's go through them one at a time. So NSAIDs can cause acute interstitial nephritis, which we've already talked about. This will lead to symptoms like fever and renal failure. And then NSAIDs can also cause chronic interstitial nephritis, which is associated with renal failure. NSAIDs can cause acute tubular necrosis by leading to ischemia of the kidneys. Prostaglandins keep the afferent arteriole vasodilated, so NSAIDs block that prostaglandin-induced vasodilation of the afferent arterioles. That leads to vasoconstriction and can cause ischemia. NSAIDs are associated with membranous glomerulonephritis, which is a cause of the nephrotic syndrome that I talk about in another video. And then NSAIDs are also associated with papillary necrosis, which we're going to talk about next. The renal papillae are the portion of the kidneys that collect urine coming out of the pyramids, and the urine then flows through the papillae and down into the bladder. So as the name implies, in renal papillary necrosis, there is necrosis of the renal papillae. The papillae have a unique blood supply that makes them particularly vulnerable to ischemia. When this happens, there is sloughing off of tissue from the renal papillae, and there will be gross hematuria, and the clumps of tissue and clots of blood can obstruct urine flow, and that can lead to flank pain. There are many potential causes of papillary necrosis, but I've listed the classic ones on this slide. As we already talked about earlier, chronic NSAID use can lead to papillary necrosis. You can also see papillary necrosis in patients with diabetes. Papillary necrosis is a classic complication of sickle cell disease, and you should know it's also been reported in patients who have sickle cell trait. In general, patients with sickle cell trait do not develop the same symptoms as patients with sickle cell disease, but this is an exception. And then lastly, patients who have pyelonephritis can sometimes have the pyelonephritis progress and cause papillary necrosis in addition to the urinary infection. So the only thing you really need to know about papillary necrosis is that it is a cause of hematuria, sometimes associated with flank pain, and it's going to occur in a patient with one of the typical triggers we talked about in the last slide. Now, when you hear of a case of hematuria and flank pain, the first thing you should think of is a kidney stone, but in patients with papillary necrosis, the workup for a kidney stone is going to be negative. The best initial test is a urinalysis. It can show red cells from bleeding and white cells from inflammation. It may also demonstrate pieces of necrotic tissue. But importantly, there will be no bacteria to suggest cystitis and no cast to suggest glomerular inflammation or bleeding. The diagnosis can be made by an IV urogram, which is a test where dye is injected into the renal collecting system. It can also be made by CAT scan. And CAT scan is often particularly helpful because it can visualize necrotic areas in the kidney. It can also exclude other causes of hematuria like kidney stones and renal cancer and bladder cancer. And the treatment for papillary necrosis is simply supportive care. In general, whenever you can, you try to treat the underlying condition. For example, stop the NSAIDs or treat the sickle cell anemia. And that concludes our module on tubulointerstitial diseases.